Hello and welcome. We are so excited to introduce Symmetry's most recent webinar, the ABCs of Compliance. Today, Kim Skehan will be presenting, but just a couple of logistical housekeeping things. This webinar is being recorded, and the handouts will be available in the chat. Early next week, you will be receiving an email with the recording as well as the handouts. And then please, during the course of the webinar, if you have any questions, please put them in the Q&A. And then at the end of Kim's presentation, we will ask her those questions and have a dialogue that goes back and forth. After all of that, I'd like to formally introduce Kim Skehan. Kim, I'll pass it over to you.
Okay, thank you, Lynn. And hello, everybody. I hope wherever you are, it's a little bit cooler than it has been across most of the country this past during this summer. So I do appreciate you taking the time to join us in our webinar today. I am Kim Skehan. I'm the Director of Compliance, Regulatory, and Quality for Symmetry. I am an RN. This is my 35th year in home health and hospice, and most of my career has been exactly in what my title says: compliance, regulatory, and quality, which we will talk about all of these aspects in terms of developing a comprehensive compliance program for your organization. My colleague, Laurie Newlun, is not able to join us today, but I wanted to make sure that I give a shout out to her. She is a senior manager on our team. She is, as a priority works with hospice compliance, but also is certified in healthcare compliance as well as healthcare privacy, and does oversee our compliance program effectiveness and risk assessments, as well as our Hipaa assessments that we do conduct for organizations. So I am channeling Laurie during this presentation and happy to answer any questions that you have, and also follow up with you following this webinar in the event that we are unable to get to all of your questions. Our objectives today are to provide an overview of the current government audit landscape for both home health and hospice providers, and state the top areas of focus by government contractors and auditors. We also will speak a little bit about survey and regulatory and some of the changes specifically related to hospice as they relate to the financial penalties that may impact hospices, and as an important note, already can impact home health providers these days. So this is a new advancement for hospice, but we know that home health already has the ability for CMS to enforce CMPs, for example, or enforcement remedies. And also, most importantly, learn strategies to implement accountability measures, best practices, and consistency in the development and implementation of your corporate compliance program. So there are three buckets of compliance with a spillover effect. And this includes Hipaa, which is overseen by the Office of Civil Rights and includes privacy and security. The conditions of participation, which many organizations are mostly familiar with as it relates to survey and certification, and also billing and payment enforcement, which is a significant area of interest and certainly caution for organizations, and an extremely important area for you to ensure that you have the billing and payment aspects of corporate compliance developed within your organization. And the enforcement here includes the home health and hospice provider manuals, enforcement by the Medicare administrative contractors, the Office of Inspector General, Department of Justice, and Medicaid fraud units as examples. We're going to talk about each of them briefly in a little bit more detail. So Hipaa, as we are familiar with, is the Health Insurance Portability and Accountability Act of 1996. We know that Hipaa has been in place for many, many years. Most organizations, if not all organizations, should be very familiar with the Hipaa privacy and security provisions. There are 5 titles, which include the NPI requirement, EDI or transactions and code set standards, HIPAA privacy, security, and enforcements. And we'll talk briefly about enforcement activity in just a moment. Healthcare providers also need to understand the HIPAA administrative simplification, which requires providers to implement secure electronic access to health data and to be in compliance with those privacy elements set forth by Health and Human Services. There are recent updates and ongoing updates for HIPAA. So it is important that you follow OCR and the HIPAA website in order to ensure that you are familiar with the updates. One update several years ago that we are familiar with is the high-tech guidance, and also the updates to business associate agreements. So ensuring that your contracts all have BAAs in place. But there are also additional updates as well as reports of breaches and settlements. We have seen ourselves an increase in reports of settlements with the Office of Inspector General, which have included the requirement to have a HIPAA risk assessment and program effectiveness assessment, as well as implementation, very specific implementation of components of a HIPAA program for privacy and security, especially when there has been a breach, whether that breach was self-reported or identified and then followed up and enforced by OCR. As you can see, a report published in the HIPAA Journal for calendar year 2021 indicated 714 breaches of 500 or more records reported to OCR compared to 642 in 2020. And we also have seen a significant increase in cybersecurity breaches, as you all may be familiar with. So this is an area of your compliance program that you want to make sure that you stay on focus. You appoint a HIPAA compliance officer. You may have a privacy officer and a separate security officer, or you may have one person one individual that meets both of those requirements, or you may have your corporate compliance officer serve as your privacy officer and then have someone in your technology team serving as a security officer. Either way, you want to make sure that you identify what those requirements are. And that is one of those three buckets that you want of compliance that you want to make sure that you have processes in place. Implement your privacy and security policies and procedures, monitor compliance, and investigate, resolve, and report breaches. Ensure patient rights when it comes to HIPAA. That includes both in sharing of the physical clinical record and also in verbal communication, making sure that all of your staff at all levels understand patient confidentiality, including whether they're using their own phones for texting, sending pictures, talking about patients in one home versus, while in another patient's home, for example. And you want to ensure administrative, physical, and technical safeguards. So the second bucket are the conditions of participation. And these are the regulations that set forth the requirements that providers have to meet in order to be Medicare certified to receive Medicare or Medicaid payments. The focus is on patient care, coordination and management of that care, quality of service, patient rights, infection control, as well as many others. And this is where many organizations, when they indicate that they have a compliance program, will focus on their survey history. So often there are times where we will hear organizations who have, for example, received a government UPIC determination or an OIG determination or even a TPE audit with 100% or let's just say 75% error rate. And they say, I don't understand. We've always had deficiency-free surveys. It's very important to understand that all of these buckets have different lenses. So in bucket 2, when we're looking at conditions of participation, we're focusing on survey and participation and meeting those requirements. They are focused on, they're predominantly patient and agency operations centered and address the health and safety of the patient. They are not payment centered and are overseen by state survey agencies and CMS, as well as accrediting organizations or enforced by those organizations. The COPs can be found in the State Operations Manual, both Appendix B for home health and Appendix M for hospice. The regulations are the conditions of participation and the standards as well as the requirements or elements within those standards. The interpretive guidelines are the guidance for the surveyors and agencies in terms of demonstrating guidance. However, it is your organization's responsibility to ensure that you can demonstrate how your organization meets the standard. So if you're surveyed and have a citation, the citation is should be related to the standard or the condition, not solely based on the interpretive guidelines. You want to be aware of updates. Most recently, certainly we've experienced the 1135 waivers related to the COVID-19 public health emergency, those survey updates, as well as the vaccine mandate and those survey requirements, as well as the Appendix Z updates related to emergency preparedness and understanding what those regulations are and those new requirements. And there are new hospice survey changes and enforcement remedies, which we'll talk about just very briefly. So the program intake, the Consolidated Appropriations Act, which was enacted in December of 2020, includes the hospice program, the hospice survey changes and enforcement remedies, which were published in the home health final rule in fiscal year 2022. They include new hospice survey requirements and new hospice enforcement procedures. The regulations are effective either starting in late 2021 or into 2022. It depends on the item. This is a grid to just show you the timing of those changes. And you can see, as I said, most of them will be implemented, either have started to be implemented regarding survey changes or specifically related to the enforcement remedies are to be implemented no later than October 1st of 2022. The special focus program is under development, and that will be finalized in future rulemaking. So what does this mean for your hospice? If your hospice hasn't had regular surveys, you will have a survey at least every 36 months. This has been made permanent. Surveyors have been trained, educated, and tested. There is additional updated training, which is free for all providers to be able to access and receive that training. But with this training also comes the potential for more condition level deficiencies or interpretation of the regulations. Surveys specifically related to accrediting bodies will also be posted for the public to review. And if you have condition level deficiencies or frequent deficiencies, you may be subject to enforcement actions and sanctions. So the most important area or most concerning area for providers with hospice providers include the enforcement remedies. And I just want to point out that these enforcement remedies are very similar to areas that are already, or enforcement remedies that are already in place for other settings, and that includes home health. CMS can appoint a temporary manager or appoint a temporary manager, also implement payment suspension, CMPs or civil monetary penalties, as well as mandate a CMS or state survey agency directed plan of correction or directed in-service training. And there are indications for termination and continuation of payments. I'm going to focus on just a couple of areas that have a monetary impact related to the survey sanctions as part of your compliance program. This includes payment suspension of new admissions. And I want to pause just to say thank you to the national associations and the state associations and all of the providers that advocated for hospices to have this implement this enforcement remedy for only new admissions for hospice versus all Medicare payments. CMPs, you can be subject to CMPs with non-compliance with one or more COPs, non-compliance with one or more conditions of participation, regardless of whether your hospice program's deficiencies pose an immediate jeopardy to patient health and safety. And this is extremely important because most of the survey findings that we see, and this is both in home health and in hospice, relate to patient documentation or patient care or home visits. So it's extreme, and it does not have to rise to the level of immediate jeopardy. But CMPs can be imposed whether the patient has, whether the agency has immediate jeopardy or condition level deficiencies, and can be imposed per day or per instance. And the number of days can go back as far as the last standard survey, including any number of days in IJ. The CMPs will not exceed $10,000 per day. There is an upper, middle, and lower range that's adjusted annually by CMS. And the considerations include the size of the hospice program and its resources, and evidence of a self-regulating QAPI system. And this is extremely important because this is where QAPI ties into regulatory and compliance. So QAPI is not exclusive of regulatory and compliance, but you want to make sure that your monitoring includes those survey findings, as well as any payment considerations or potential compliance issues that you have identified. There is also an administrative hearing process. This is just a brief chart to show you the differences in the ranges. I will say in our experience, we have had many years experience working with home health and CMPs, as well as hospices who have had state enforced fines. And we typically see that those fines do run somewhere in between the middle range. The top, just as a brief review, the top 10 hospice survey findings include, as you can see, the majority of those findings are related to the plan of care, as well as comprehensive assessment, which is why that documentation, the documentation of the assessments, the plans individualized to meet the patient's needs, and addressing the patient's status changes ongoing is so important, having both this documentation and the clinical documentation, and also reflected in the care that's provided to the patient. Another top area for both home health and hospice includes infection control and prevention. This typically is related to home visits, whether it's hand hygiene, eating CDC guidance and your agency policy, bag technique, cleaning and maintaining equipment, but it also includes areas such as vaccine mandate tracking, infection control tracking, TB testing in relation to your policy. So this is a big area. As you can see, it is a heightened area of review for survey. It's a priority. So it is an area that you want to make sure that you address ongoing and you monitor. And then also hospice aid assignments and duties. For home health, you can see, again, this is related to the content of the comprehensive assessment, the plan of care, same with infection prevention and control, clinical documentation, as well as physician conformance with physician orders, and promptly alerting the relevant physician of any changes. So again, that real time, making sure that we are managing the patients, changing the plan of care in order to meet the patient's needs, and notifying the physician. So the third bucket is related to billing and payment, and that's what we're going to spend a little more time on during the course of our presentation. The sources for enforcement here or for regulations include the Medicare Benefit Policy Manuals, both Chapter 9 and 7 for home health and hospice, and the claims processing manuals for each service line as well. You also can refer to the Program Integrity Manual and check the CMS website for those current manuals. And it's important to understand that there is some spillover from the COPs to payment requirements. If the payer requires that there are conditions of participation that must be met, such as having a plan of care updated, in a certain period of time, to have orders to provide services or orders for frequency, those are areas that may cross into both survey as well as payment. But when you are appealing any findings related to claims denials, you want to make sure that you are clear on what the reason for the denial is and where you can differentiate or be able to demonstrate your compliance with payment regulation. And if you are able to argue that if you're compliant with the payment regulation, you want to make sure that you can differentiate between the two. So why are home health and hospice providers targeted for focused audits? Home health and hospice will continue to increase with the increase of Medicare beneficiaries. Specifically, CMS is very interested in monitoring spending outside of the Medicare hospice benefit. We certainly see that with Part D and medications, but also now more frequently with physicians and physician billing. Overpayments and fraud and abusive practices are real. If you read the DOJ summaries and the OIG findings, you know, there are opportunities where providers may not have known or have intentionally committed fraud, but there are many times where you can read where actual fraud has occurred. So in all settings, so you can see where the focus is and why the Office of Inspector General is so focused on monitoring these areas. There are government initiatives and also those reports that demonstrate patterns or potential abusive practices, such as, for example, those reports on, we saw a few years ago for survey issues or for hospice and nursing facilities, or now we have an OIG work plan item for therapy. So it's extremely important that you monitor the OIG work plan items and those corporate integrity agreements and reports to be able to see the focus areas that the federal government is reviewing and what they're finding. Another way to be able to help yourself in proactively addressing areas or identifying what may be targets of an audit include those data comparisons, and you have the ability to have retrieve your PEPR data, which the Department of Justice and the MACs also review. And in terms of for trending, not necessarily individual findings, but that's how they identify what those thresholds are or those focus areas that they are going to target. And you can see in the audit requests that you receive from any government entity, they tend to mirror the trajectory of some of these areas that we know are already being tracked through PEPR data. And then the government data also looks at state, regional, and MAC jurisdiction and national data. Oops, sorry. Example of government audits. This is the alphabet soup of government auditors. And so when we use acronyms like SMRC, OIG, RAC, CERT, UPIC, or ADR or TPE, there is a name and a purpose behind each of these audits. It is extremely important that if you receive a letter of an intent of an audit, you want to make sure that, or an additional data request, you need to make sure that you know where this request is coming from. Is this a targeted probe and educate from the MAC? Is it a CERT from the MAC? Is it a SMRC? Or is it an OIG investigation? Or is it a UPIC? It's extremely important to know the type of audit and where the audit is coming from in order to make sure that you are aware and you are addressing what the requests are and providing the documentation to be able to support your claims. The OIG does complete program integrity audits, which is a random sample of 100 claims per provider. Those findings, when you submit those findings and those additional document requests for the OIG, if you have denials, there is the potential for extrapolation. There is a draft issue, a draft report issued, and you do have the ability to respond, but those reports are made public. RACs are the recovery audit contractors, and it looks as though the key areas of focus are a little older. However, I will tell you that we have recently seen RAC audits for home health providers and SMRCs for hospice. So we do see these contractors still reviewing and auditing different claims for different providers. So it's very important that you're aware of the different type of an audit. The other component to a RAC is, or the other potential component for a RAC is a referral to the recovery audit contractor, potentially from the Medicare administrative contractor, such as NGS, Palmetto, or CGS, related to a provider going beyond the third round of TPE. UPICs replace the ZPICs and other program integrity activities. We do continue to see UPICs for both home health and hospice. This is important. Again, it's different than a straight ADR or a straight TPE in the respect that that there are sanctions that can be put into place. And this includes potential extrapolation, but also they can put an organization on 100% prepayment audit, or in other words, everything will go into an automatic ADR, very similar to an RCD state. So you want to make sure that, again, if you are under a UPIC and that you are scrutinizing that documentation, certainly before it goes to the UPIC, that, you are prepared to appeal if appropriate. And also that you review your documentation going forward on a pre-bill basis so that you can mitigate any potential future findings or any future denials. I would also say that with these government audits, it is important that you also engage in counsel who is knowledgeable of these government audits for both home health and or hospice, depending on your setting. So the UPICs, there are 5 jurisdictions. You'd be familiar with the names Safeguard, Covenant Bridge Group, or Qualerant. Again, you want to know these names because these names are different than NGS, Palmetto, or CGS. The MACs that I just mentioned are implementing targeted probe and educate. And I actually have a couple of slides here because this is such a hot topic. I feel as though everybody is under TPE these days. And we certainly see that. The MACs are looking to ensure that the payments are made appropriately. The term is targeted probe and educate, with the intent of providing education if an organization has a high error rate, depending on what the threshold is for that particular region. Let's just say it's 15%. The issue here is that if you exceed the threshold, then you are automatic on the first round. You submit your documentation, you exceed the threshold, you have the option of education from the MAC prior to the second round. You can also appeal any denials. And however, even if you win on appeal, you still will be moved into the next round. And the risk here is that if you are to move into the after 3 rounds, then you have the potential to be referred to CMS for 100% prepay review, extrapolation, or referral to a RAC, as I had said before. So you may see requests for 20 to 40 records. You want to make sure that you submit those documentations in a complete manner. We do work with organizations in terms of working with them to make sure that they understand the components that need to be submitted with an ADR. And we'll do a preliminary review just to say, just to give recommendations or findings on the strength of the documentation. And then appeals, you want to make sure that you are reviewing and appealing if possible in order to be able to recoup those dollars. But remembering that the secondary responsibility here is really to ensure that you have an effective pre-billing process, a pre-bill audit process, to mitigate any future high error rates in the future rounds. So some of the areas of focus for home health include a face-to-face encounter and the completion of the face-to-face encounter, timeliness, diagnoses, matching the plan of care, face-to-face and who is signing the face-to-face encounter, skilled need and medical necessity. We see that for long length of stay, but also for short length of stay, even under PDGM. Homebound status, therapy utilization, especially around duplication of service, as well as services provided without the reassessments as required. Technical, meaning signatures and dates on 485s, those ICD-10 coding and OASIS coding documentation inconsistencies, particularly around ICD-10 coding and as they relate to the primary reason for home care, what's on the plan of care, and what's on the face-to-face. And also the use of COVID-19 telehealth and PDGM comorbidities. Also from a fraud and abuse perspective, looking at referral relationships and potential incentive programs, and looking at those items that are on the Pepper report, which is why it's so important that you download those and read those. These are the top areas that I just discussed regarding some of those home health denial reasons. I would have to say, and I agree with this, that medical necessity or evidence of skilled need, especially on the longer length of stay patients, is extremely important to support that documentation. We've also seen recently LUPAs, which are intentional LUPAs, for example, Foley patients who are Foley catheter patients who are long length of stay, and those records also being scrutinized under audits. For hospice, eligibility and medical necessity to support the 6-month prognosis, certainly from the start of care, but really for your long length of stay, especially over 180 days. Although we have seen denials for the benefit periods 1 and 2. So it does depend on the documentation to support eligibility. Appropriateness for the levels of care, particularly around general inpatient level of care and continuous home care. When we are the independent review organization for organizations that are under Office of Inspector General corporate integrity agreements, we can say that the majority of those hospice IROs that we work with relate the areas we need to focus on are long length of stay and GIP. Patients in skilled nursing facilities and ALFs, and looking at that relationship, what services are being provided, and also the technical requirements, making sure that all of those documentations all of that documentation is completed correctly and timely. The CTI, the certification of terminal illness, ensuring that information, that the CTI narrative is complete, also that the face-to-face is complete, and that they also have, especially the CTI narrative, the medical director or hospice physician documents clearly the support, the rationale for the patient to be continue to be eligible for the next benefit period. Also looking at the Medicare spending outside of the benefit related to Part D. And as I said before, more and more we're seeing this with hospice physicians. Inappropriate referrals, meaning referrals that are being made where the patient is not eligible for hospice. Also those incentive programs that we talked about, even with home health, those relationships with nursing facilities, as well as paying the hospice medical director more than fair market value. And I also will say that another area for pause is when there is a hospice that is not a large hospice that has one hospice medical director, but multiple hospice physicians, or what they sometimes refer to as associate medical directors. So really looking at who you have, within your organization and what could be construed as a potential referral relationship issue. And again, the Pepper reports. This is just a listing of the hospice denial reasons, and we talked about virtually all of them already. Making sure again that documentation supports that each visit certainly has some element, and that means by all disciplines, element of what is the skill that we're providing, why does this patient remain eligible, and that evidence of care and coordination of care with the interdisciplinary group. An area that you do want to make sure that you monitor are the OIG work plans for both home health and hospice. In our case, we look at the OIG work plans for other settings as well. It used to be that the OIG work plan was updated annually. It is now updated ongoing throughout the year. So you want to make sure that you're checking that periodically. One of the areas I'll just point out here, in addition to the therapy services work plan item that I just referenced before, also had to do with infection control at home health agencies during COVID-19, public health emergency, as well as health. One area that I think is important to note is Medicaid home health services for beneficiaries with chronic conditions. This is important if you are caring for patients who are dually eligible. In other words, eligible for both Medicare and Medicaid home health services. You want to make sure that your clinicians are very clear on whether the patient is whether they're not eligible, they don't meet eligibility for Medicare, or they do. So if a patient is receiving services under Medicaid, and because they are not homebound, you want to make sure that your clinicians are very clearly documenting that how why the patient is not homebound on an ongoing basis. So that because this is what the OIG is looking at, is our patients who are on Medicaid services, would they also have been eligible for Medicare? In some states, that's called TPL, third-party liability. And for hospice, you can see the areas that, for the most part, we have discussed. Certainly, they're continuing to review hospice inpatient and aggregate cap calculations, and definitely the payments outside of the hospice benefit, and the frequency of nurse on-site visits to assess quality of care and services. We know that this is also this is also a similar review or data that CMS is collecting related to hospice quality reporting. So if you receive an audit request, the first thing that you want to do is make sure that you identify that type of audit. Don't panic. Oh, and find out who is the auditor. When we receive a call that someone received an audit request or any sort of denial, that is our very, very first question. Who is it? What type of audit is it? Who is the contractor? And the second question is, what is the due date? Because we want to make sure that we don't ignore any of those due dates. You don't want to ignore the letter or let it sit on your desk, as they are time sensitive. You want to take immediate action by notifying your compliance officer or administrator, whatever your process is. Consider engaging legal counsel and potentially an outside firm to assist with reviewing this documentation and making and determining what the likelihood or ability or the likelihood of denial may be. Also to make sure that you understand those processes and what is expected to support those that ADR, because many denials, first round denials, are often the result of not sending in all of the documentation that was requested. And you want to plan for an appeal. More and more we see that if there are denials initially, that when you go to the next levels of appeals, such as redetermination, reconsideration, up to administrative law judge, very often those findings, there are times when they do change, but a lot of times they don't. It feels as though the same, there are the same findings. You have to be able to continue to argue your appeal until you get to, most of the time, the administrative law judge. I will tell you that we waited years for ALJ hearings for many. We're now doing hearings for patients as far back as beneficiaries as far back as 2013 in some cases. But I will tell you that recently the OMHA, which are the ALJs, the administrative law judges, have added judges and are really stepping up the time frame. So you may find that if you had submitted an ALJ request even a few months ago, you will start to see some activity on those hearings, which is actually excellent for providers. But it used to be that it was an automatic 5-year wait. Absolutely not. It's definitely coming a lot sooner. So if you have any pending, you can expect to hear about ALJ activity very soon. And in those cases, you would definitely want to have counsel and often an expert witness. We serve as expert witnesses, but both for clinical, for home health and hospice, but other organizations also as well. And you also may want to have your own expert witnesses, including your medical director, specifically when it pertains to hospice. So how do you start with implementing and ensuring that you have a comprehensive corporate compliance program? You want to establish a formal compliance program with the 7 elements as set forth by the OIG guidelines for home health and hospice. They're on the OIG website, but there also are updates from the DOJ, which are also found on the website. And you want to frequent that website to identify any new CIAs and what those focuses are and what those recommendations are from the Office of Inspector General for implementation. If you have other settings, if you have physician practices, such as if you have palliative care and you have a physician practice or behavioral health, or you want to make sure that you're looking for corporate compliance guidance for those settings as well. When we conduct compliance program effectiveness and risk assessments, we actually conduct them, again, not just for home health and hospice, but we do conduct those assessments for all settings. So we utilize the appropriate resources. So if you're part of a health system or you have other service lines, you want to make sure that you're looking at the OIG guidance to see what guidance will be applicable to your setting. It's important to note, though, that the 7 elements are consistent throughout all settings. You want to make sure you have your policies and procedures with a written code, compliance officer and a committee, training and education, both initially on orientation and annually. Communications, what that looks like in terms of anonymous communication, a hotline, what your auditing and monitoring processes are, so both internal, external, ongoing, and that will change depending on the setting in terms of what those audit priorities are. Disciplinary measures, and what your process is for disclosure and timely investigations and reporting. So for accountability, in terms of strategies for implementation, you want to ensure basically everyone within your organization, from the governing board to every single staff member in your organization, volunteer and contractor, understand your corporate compliance program and what your expectations are and your code of conduct. You want to make sure that from your governing body all the way to the executive team, marketing team, HR, clinical management and staff and care providers, again, both employees and contractors who are also held to your standards, as well as your rev cycle and billing personnel. And there may be additional staff that may be included. If you look at some of those CIAs, those corporate integrity agreements, they sometimes specify some additional team members that also need to be included. And definitely including, for example, your marketing team. You want to create a dedicated compliance team, appoint a compliance officer or manager who has that requisite education and training. You want to ensure that even if you're an organization that has multi-location providers, that you ensure that you may have a corporate compliance officer, but you want to ensure that at the local level, you have someone who is responsible for implementation of your corporate compliance program. And it may roll up to your corporate compliance officer or corporate entity. Educate your staff on how their documentation forms the basis for billing and payment. So in addition to instructing your clinical staff regarding the conditions of participation and that documentation, they need to understand program eligibility, program payment, what documentation do we need to make sure that we can support eligibility, skilled need, other requirements. You want to conduct a forms review. And when I say forms, it's not just your paper forms, but your EMR, to make sure that your processes and your forms are in compliance, meet the intent and compliance of the payment and the payment regulations and the COPs. You want to conduct pre-bill audits and use data analytics to track those billing patterns. So use those PEPR reports and other reports that may be available through your EMR for dashboard measures and patterns and percentages, because self-monitoring reduces the likelihood of abusive or reckless habits and potential overpayments. And again, consider external auditors, whether it's your larger organization and you have an external entity or an outside auditing firm, to be able to conduct quarterly or annual audits and education as part of your corporate compliance program implementation efforts. You want to identify those billing and payment issues under scrutiny and develop an audit plan, and distinguish between compliance audits, meaning payment compliance, and survey compliance and QAPI. So you want to, although they are interrelated, there's some similarities, and they are interrelated in some ways. They are not the same. Those activities must be, you must address them individually. You want to frequent those websites and use additional resources and industry experts to be able to stay on top of what the new new compliance or regulatory requirements are, or billing requirements, or or any new audit activity. For best practices, you want to educate your governing board and your executive team. There is guidance for governing boards on the OIG website that are extremely helpful in terms of ensuring that your governing board understands their roles and responsibilities in compliance. And also making sure that you have that hands-on documentation, training, and practice consistent with the regulations. And again, the education on payment requirements, not just the COPs. Ensure that everyone, including physicians, nurse practitioners, therapists, chaplains, social workers, in addition to nurses and aides, are in addition to RNs and LPNs and aides, you want to make sure everyone is included in that training. And again, that pre-bill auditing and monitoring for eligibility and technical documentation requirements. Remember, and I would suggest here, optimize your EMR regarding any technical edits that can be put into place in order to help to the efficiency of technical pre-bill audits. But it is also important not to rely solely on technical edits, because many of the denials come from clinical documentation. So what does that process look like within your organization to ensure that that the clinical documentation meets eligibility requirements, eligibility and regulatory requirements? You should have somebody within your rev cycle and billing department who understands the regulations and payment requirements and can work with the EMR regarding any billing and rev cycle impact issues. Ensure that there's that implementation of pre-bill edits before the final claims are ready to bill, and whatever that process looks like for you. For HR is an extremely important area for compliance. You want to ensure that you have your OIG exclusion checks. We recommend monthly. OIG recommends more frequently or monthly for employees and key contractors. Making sure, and in many organizations, they also run OIG checks on some of their referring doctors or referring doctors or entities. Most definitely, at minimum, you want to have an OIG check on hire, but we certainly recommend it more frequently. You have a code of conduct or standard of ethics, again, introducing that on hire and signed by everyone, as we talked about, including your vendors. An annual employee attestation, as well as setting up expectation of an exit interview on hire if you're able to do that, and implement disciplinary practices. Be very clear within your code of conduct and your policies what your disciplinary practices and policies are for any identified areas of actual or potential non-compliance. And also your processes and security of access to your EMR and the settings and what that oversight looks like. Your marketing team, ensuring that they also have training and education, role playing, and reviewing any of your bonus plans for employees, but make sure also that you don't have any bonus plans for independent contractors. Our growth solutions team does a wonderful job in terms of training for marketing, sales and marketing professionals, and also looking at these structures within organizations to provide recommendations and in terms of how to implement effective compliance programs for your sales and marketing team. You want to develop an annual audit plan to ensure consistency and oversight for compliance and Hipaa program effectiveness and risk assessment. Whether you perform it internally using the guidance or you have it performed by an external resource, present this information to the governing board, and includes a summary of ongoing monitoring and auditing of those key areas, identifying any overpayments and what your plan is for timely reporting and repayment, because there are timing limitations on once you have identified an overpayment in terms of self-disclosure. You do want to make sure that if you do identify overpayments, you do utilize counsel to be able to assist you in what the determination is for next steps in terms of further investigation. I would also point out that if you conduct post-payment audits, we talked a lot about pre-bill audits so far, because with pre-bill audits, it's a presumption that if you determine that the documentation does not meet eligibility, you don't bill the patient, you get the order signed that needs to get signed, whatever, you need to make sure that that record is in compliance, or you don't bill for those portion of services. However, if you are reviewing post-payment records, we do recommend that those post-payment audits are conducted under attorney-client privilege in order to be able to work with you in terms of what the next steps may be in terms of any potential reporting. Your corporate compliance and survey readiness within your organization as part of your overall corporate compliance should be an ongoing agency-wide effort, making sure you're educating all levels of your staff about the federal and state home health and hospice regulations, including the COPs and conditions of payment. You want to conduct mock surveys for the survey perspective at least annually using survey protocols, train staff and managers regarding survey processes and regulatory compliance. Make sure that all staff and managers and volunteers and contractors understand the agency's corporate compliance plan and each individual's responsibility. And above all, holding staff and management accountable for ensuring compliance with regulations and also compliance with your corporate compliance plan. Remember that compliance is everyone's job and requires consistency and continuous oversight of practice. And I borrowed this quote from Janan Griffin on our team because I happen to love it. Readiness for opportunity makes for success. Opportunity often comes by accident, and readiness never does. So making sure that your organization has a proactive, both comprehensive compliance program addressing Hipaa, survey readiness, and payment compliance and billing compliance is extremely important. And with that, I believe that I have time for questions.
Thanks, Kim. That was a great presentation. We have a question from Ricardo. Does notifying the physician mean an order requiring a physician's signature, or is a verbal communication with annotation in the record acceptable?
Can I see that question?
Yeah.
Oh, I see it. Oh, okay. So the answer there depends on what the notification is. Let's start with that. If it's a notification in the record that you've called the physician, contacted the physician due to a change in patient status, that is a communication in your record that you would see. If you obtain an order for further service, for care, for med change, for any frequency change, then that requires a verbal order and response from the physician. Ideally, what we like to see is a note in the record, in a communication note that says, the physician notified regarding, the patient's changing status, and then there's a loop back from the physician's office with a subsequent verbal order with any changes in the plan of care. I hope that answers the question.
We have no more questions, but we will be sending an email early next week with the recording of the webinar as well as the handout. And if you have any additional questions, please reach out to Kim, or you can contact us at marketing@symmetryhc.com. Thanks again, everyone.
Thank you. Thank you, Lynn. Thank you, everyone.